This is Caroline.
Maritess.
Neil.
And this is Laura. Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud Med Surg nurses, just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Today we're talking about diabetes and how we can empower collaboration between our patients and their families. But before we get started, let's see what's new with everyone. Neil, why don't you start?
Graduate school has started. UNCW has been my final choice. It started about a week ago, shortly right after my 49th birthday, the big 49. Had a small get together with some friends. I'm naming this part of my life Fast and the Furious. It is 7-week semesters. So if I'm not reading something, I'm posting something. If I'm not posting something, I'm researching something. Then I might sleep and eat and go to work in between that. Graduate school has been a very, very welcome challenge right now. Some other small news is like my little dog had to have some surgery. One of my pit bulls named Blue, he had a little stylic on his eyelid. And so he got that taken care of. And unfortunately with that, they told me he has a small mast cell tumor on his leg. So he'll be getting some medicine for that after his eye recoups, which is a pretty brutal treatment. It kind of necrotizes the tumor and the flesh area around it since it's non-operable due to it being on the Achilles tendon. Other than that, welcoming the challenge of graduate school for my nurse educator. Caroline, what's going on with you?
Well, Neil, I remember those stories of graduate school very well. I'm not sad to say those days are behind us for sure. Like you said, if you're not reading, you're posting. If you're not posting, you're reading or doing some kind of research. But it'll all be worth it in the end. Here in Georgia, I'm happy that Ted Lasso is back on Apple TV for season 3. If there are any Ted Lasso fans out there, I just got done with the 1923 prequel to Yellowstone. I haven't watched one episode of Yellowstone yet, but I enjoyed 1923. And so Harrison Ford is everywhere now. He's jumped ship from Montana, and he's now in another Apple TV show called Shrinking, I think. Shrinking, yes. He's a psychiatrist with Parkinson's disease. Very interesting premise. So anyway, I've just been sat in front of the TV, basically binging on all of these shows on Apple TV. Laura, what have you been doing? Anything more productive, I hope?
Oh, there's always productiveness going on. I am in the middle of reorganizing my craft room. It's been interesting. I think I've shared on this before that a few years ago, our house flooded when we had a pipe burst during a freeze. So we packed up a lot of our stuff. And my closet was just full of all of these boxes. I finally went through them, and there were baby pictures and old journals. It's been a lot of fun. So productive, I'm not sure, but it sure has been fun reviewing all of those things, all of those memories from life. And at work, things are going well. We are just about to start doing a big push because, as you know, this was certification day, or I think that was actually yesterday, was the National Certification Day. So we were planning a big celebration at the hospital today. So that was a lot of fun. Maritess, anything new with you?
Well, I am very excited to share this update. Guess who I saw last week in a conference? I actually saw Alisa.
Alisa, one of our alumni.
He is one of our original podcast co-hosts. I am very, very excited. When I saw her on the first day, I actually saw someone. I was like, I think I know that person. And so I took a risk. I shouted, Alisa. She turned around and she said, Maritess. And so everybody knew also who I am. And I was really very excited because you know how we talk here in the podcast, we share ideas, and we really don't have the opportunity to really see each other in person. So that was really very exciting. I asked her how school's going. She was so very happy to share with me that her title got approved. And so I said, okay, Alisa, looks like you have some free time now. Maybe you can join us in one of the episodes. And she was like, I don't think so, but maybe I can. So maybe that's something that we can think about. Another update I wanted to share as part of what happened last week was during that conference, I won this hackathon. A hackathon is wherein you are going to be given different sorts of problems or challenges, and you're going to solve them like a hack. You create a solutions to the problems. And so we were given different puzzles, different tools on how we can solve the problem. There are actually 64 teams. They formed 16 out of the 64 members. 12 people won, 3 in each group. It's the first ever hackathon that they did in that conference. And so I was so very happy to represent my team and bring the best out of myself with people that I don't even really know. It's the first time that I met them in a conference, and we grouped together as a team and kind of figure out a problem together, and we won a gift card.
That's great. Congratulations. That's wonderful.
Very, very exciting. All right. Well, then let's move on to our topic. And today's topic is one I suggested, and it's about diabetes and how we can empower collaboration between our patients and their families. This topic came about with one of the newly hired nurses who is also 2 months in nursing. She shared with me that she was having trouble with a caregiver, primarily the wife, bringing sodas, pizzas, sweets in the patient's room, the husband's room. At first, she really wanted to stop her and say something, but she didn't want to offend the person. So she tried to say, you shouldn't be bringing that. And then, of course, she kind of got upset. She got reported to the manager, and I said, let's stop and reflect on that. Why do you think it wasn't really a good idea to say you shouldn't be? I asked her, why do you think it's not a good idea to say that way? Perhaps maybe you could have said it in a different way. And she said, that's my problem. I really don't know how to bring that up. I didn't want to offend her, but it's really bad. I wanted to even say that you're worsening this condition. I said, okay, I'm so glad you didn't say anything like that. So I really wanted to share and ask your opinion about this. How do we empower caregivers, family members when taking care of patients? And we'll make it very specific for this episode, diabetic patients, because it's true. We love them. We want to care for our family members. We want to care for our loved ones. But how do we make it meaningful, and how do we empower them?
I think that's a great question, Maritess. And I think one of the barriers to empowerment is orders and order sets. And in so many areas of nursing, we have come such a long way with nurse-driven protocols. It's almost as if we need to get together with endocrinologists to come up with a nurse-driven diabetic protocol. Now, that's a pretty wild statement, because we're dealing with medications, and too much or too little can do a whole lot of damage to our patients. So I think we take a step back and we involve the patient in a way that we never truly do. We really sit down with them and say, okay, you're in the hospital, you live with your diabetes 24/7. We're about to see a very small snapshot of what you do, and we're probably going to mess this up with the order sets that we have. Any endocrinologist really shivers in my organization when someone with type 2 diabetes comes into hospital, because our protocol states that we hold the meds and put them on insulin. And type 2 diabetics do not take kindly to that. And we don't collaborate with them, and we don't ask them for their opinion. And then we end up messing up their whole regimen, and they end up staying longer and everything else that goes with that. So there's kind of two separate topics or two separate conversations about empowering our patients with type 2 versus type 1. Certainly from my experience, most type 1 diabetics, we have to change their regimen because they're not as mobile as they normally would be. Their calorie need is less, and probably for the first time in a good while, they're actually having a carbohydrate balanced diet, and all of that has to come into play. So saying all that, how do we empower them? I think we include them, and I think that we have much more meaningful, intentional conversation. And then that conversation turns to the prescriber We say, look, this is what this patient does at home. How can we modify this to a reasonable plan so that we're not causing hypo or hypoglycemic events, and we can get our patients home in a reasonable amount of time without really high or really low blood glucose? That's my initial thought on this.
Very good points, Caroline. I also want to say, I love the idea of a nurse-driven protocol. I mean, I like the idea of that, of having nurses be a little bit more involved. But I think one of our responsibilities is to really assess what the patient understands about their own disease. They might be taking medications or taking insulin at home and not recognizing how all of the factors come into play, their exercise regimen, their nutrition, and the medications. So we need to do a really good job at the beginning of assessing where the patient is so that we can tailor our education to meet them where they are.
You're both so right, and I agree with everything you said there. It's a very dear topic. My brother is severely diabetic. He's now in the stage of being in dialysis from his diabetes. As we know, once you don't treat your diabetes, it just goes down that cascade of hypertension, dialysis, kidney failure. And I actually have a very good friend. Her mother is the same age as my brother. And it's amazing when you take care of it. She's barely on any oral agents while my brother is at the stage that he's at, waiting for my kidney. Living in North Carolina, there's a big soda fascination. And so I'll tell them, instead of a Dr. Pepper, try a black cherry seltzer water. It's not the same sugar content and everything, but sometimes it's just the effervescence of something like seltzer water that will substitute for it. And it's empowering our patients to make smarter choices. Sometimes they're not as knowledgeable about what carbohydrate is. We tend to forget potato is just as bad as some pasta, as bad as bread, as bad as alcohol. All of those things will spike up blood sugar so quickly. I can't empower this person if I don't know that they truly know what a complex carb is or a simple carbohydrate. So if I'm not sitting there having these very genuine conversations, and the tough part for us as nurses is, when do we get some time to really sit by the bedside with them and not be hit with a nutritionist who's going to come at them at a very high level of understanding, and all these endocrinologists? In the end, it's the nurses that are the ones really trying to take their time to engage and encounter where they're at and assessing it and meeting them and empowering them to make choices. Because we all know this, when we get to actually have some input, we're more than likely going to follow, whether it's a care plan, academia, diet plan, an exercise plan, where we have some input, we're going to be more compliant.
Isn't that so interesting too? Like, our patients don't even understand what their A1C is or how A1C is being measured. More so family members. Do they really understand what that is? How do we really make them involved? Endocrinologist, interdisciplinary team, patient education. I think it also boils down to the reason why some of them wouldn't want to be involved is because they are denying the situation. How do we really deal with that? I did share with this new nurse. I asked her, have you tried sitting down? I agree with you, Neil. When is the time that we really had this chance to sit down with our patients, sit down with the family members? In our facility, one of our facilities, if I may say, we do have a diabetes box. We have all these information for our patients. We do have different tools and resources that we provide them. I always forget, I need to give this to the family members too. I need to give this to the caregivers, because when they are at home, they're eating together. They would dine out. One would have ice cream. Okay, I'll get so many ice creams too, or more potatoes, right? When do you really say, no, you can't have that much? We also forget the fact that we need to take care of them as caregivers. We need to be on top of their appointments, because most likely they don't want to go. That's based on experience taking care of diabetic patients, especially those who are newly diagnosed. They are in the stage of denial.
They're almost clueless at the beginning. We send them away with all of this documentation. You could print out an entire book and send it with them when they go home. There's so much information out there. But we have to start with the basics, and we have to try to engage them to really understand. Because I know one of the things that used to surprise me is, I don't remember where I got this, so I can't cite the source. But fewer than 10% of people actually get a chance to go to an actual diabetic class and speak with a real diabetic educator. So now the bedside nurses are the diabetic educator. There are patients out there that think as long as they take enough insulin, they can eat whatever they want. As long as I take enough insulin and get my sugar back down into the right range. And that's just not how it's supposed to be. So we have to take the reins and encourage them to really understand how it all works together. They've got to pay attention to their foot care. They've got to pay attention to their cholesterol levels. It's not just about keeping that blood sugar number within the range. We've got to look at everything else and how it all fits in. So we've got to figure out a way to make it maybe a little less scary and help them realize how important it is and how all those things fit together.
Working at nursing homes, I just remember 2 or 3 little old guys that exactly like you said, I'll just get extra insulin. It's okay to have this extra cookie at dessert. I hate to say it. That was my brother. A lot of times when he first became a diabetic, and I always got frustrated with him. I was like, he's a chef, ironically at a hospital. It's like, you know the difference in what you're supposed to be doing. But I do imagine it's a hard pill to swallow. My guilty pleasure down in the South here, I have to say, as a Northerner, is some sweet tea once in a while. So it's making those little changes. But yeah, it could be very frustrating when that just give me more insulin mode hits.
Yeah, and you need to define what once in a while is. It can't be like once a day. My father has a sweet tooth, and that is one of the hardest things for him. He's always been kind of right on the line. He's never needed medication, but the doctors keep checking his numbers. And now I can see him hesitate a little bit before he goes in for something sweet. It's definitely sinking in with him finally after all of these years.
It's a once a month sweet tea fascination I have. But to go back to Maritess, I'm really interested about this diabetes box. What goes into this box? I'm always down to start something new anywhere, especially more population down in this area is such a huge diabetes population. So tell us some more about that box you had mentioned.
I love that you asked the question. I'd be happy to share what is in the box. We explain what diabetes is. And these are huddle cards that we can share with family members and the patient as well. And there is also a card inside the box that has the date, the time, and the result of their blood sugar. What is a blood sugar 1 to 2 hours after meals or before meals? And what are the things that they need to do to keep their blood sugar within the level? So if they love to exercise, find an exercise buddy to exercise with. If they love eating certain foods, there's a replacement that is also in the box so that they can replace it with certain food replacements that they can. If they also would like to have references from the American Diabetes Association, there are references materials that they can actually copy and paste in their browser, and that would also be their resources. The best part there is, of course, their physician. You know how they do not even know who their doctors are? Caroline brought up a very good point. Have a endocrinologist and they don't even know who to call. So there is a space there wherein they're actually going to write the name of the physician and where is the clinic and the number of the physician. So it kind of empowers really them to be accountable for their care. And the family members also there should be there to know all these resources. We call it the diabetes box, but it's also color green. So some nurses would think that, oh, where's the green box? And, that's kind of like the code. It's a diabetes box. Because we don't want to call it, label it as, oh, it's for the patient with diabetes, right? We don't want to offend anyone. So can you get the green box? So not sure how you want to call it, different box in your facility, but it kind of gives them the idea that we do have resources. If you do not have a diabetes educator in your facility, perhaps you can be a champion in your unit, create that box for everyone, and that can also be shared to family members.
We created almost like a discharge education sheet for newly diagnosed diabetics at one point. I can't remember all of the specifics of it, but it talked about what your A1C is and like a brief definition of what that is. So when they go to their doctor's office, they have this piece of paper in front of them that says, this is when I was in the hospital. This is my A1C. This is the insulin regimen that I was on. And it gives them spaces so they can keep track of their blood sugar levels when they go home, and then a place at the bottom to write down when their next appointment is. Something like that, just a little bullet point to make it easier on those nurses when they're discharging the patient to make sure they cover all of these important topics.
And you know what I really like about that is that when you're explaining it to the patient, it gives them the idea of their next steps. This is the next step. This is what you're going to do. And so explaining it to the family members too will empower them and say, this is not your journey alone. This will be our journey together. We need to change our menu plan at home. We need to change our activities, which is great.
I think it's a great little cheat sheet to give them. And I think that is one of the tougher parts too, is when you have a diabetic that comes in and works so hard to just get onto orals. And also we go, no. A lot of times the hospital is guilty of putting them back on insulin. So I think it's a good reminder for them, a good physical reminder of those little things of what I need to do. And when we do draw family members on, especially a lot of older couples, I'll say in this area, you still have the wife that will cook everything for the husband. The good thing about it is you empower that wife to not use as much starch and carbs with stuff. They're the ones doing most of the shopping. So it's sometimes it's that lack of just those little minor tweaks. But I might start implementing this on some of the Med Surg units. I really like the idea of like a green ticket, green go, get out of here.
That's awesome.
Yeah, you can even leave some of those items blank and let the patient fill them in as you're doing the discharge, so that puts another little action that they can do themselves. They can write down, I can say, okay, what was your A1C? And they can write down their A1C. It's a way to facilitate that education and make it a little more active instead of passive for that patient or the family member that's at the bedside.
Laura, you bring up a really good point there, especially when we have a new diabetic. We kind of go into the diabetic educator mode and we throw all of this information to our patients. And if the family are there, we'll talk to you as well. But I think we forget what it must feel like, or we don't extend any empathy to imagine what it's like being on the receiving end of all of that information. And we have to take sometimes a much less enthusiastic response in as much as we give a little bit of information, then allow for the patient to give us feedback on that information so we can assess what they understood. And every time they say something that makes good sense about carbohydrate counting or metabolism or activity, that gives us a moment to manage them up and reaffirm that what they're hearing is correct. And that in itself is one of the best empowerment tools out there, because they don't feel like they're being lectured. Patients said to me in the past, I get so sick and tired of everyone telling me what I've got to eat, what I've got to drink, what I've got to do. You have no idea what this is like 24/7. And that's a very sobering moment. It's like, you know what, you're right. And so then it triggers the conversation, well, share with me what your 24/7 is like and let me know what it is that you absolutely cannot give up food or drink wise. And then we figure a way to incorporate that, everything in moderation. We try so hard not to talk about a diet for this or a diet for that. When Weight Watchers first got going, they used a modified diabetic diet all those years ago. They count carbohydrates. And that's really the crux of all of this. And so I think that's a real moment of empowerment when the patient says, oh, so I can eat that donut if I want to? I could have a real Coke? Well, sure, but you don't want to do that 3 times a day, 7 days a week. No one needs to have all that pure, unadulterated sugar. But drink that Coke, then take your blood glucose and just see what that does. It shoots it sky high.
Or split it with someone, drink half of it. Yeah.
The simplest form of sugar you can get. It's not healthy. So there you go. Split it with someone, have a little taste of it. So I think we go into nurse mode, teacher mode, and then we forget, my gosh, I'm just going on and on and on, and I'm lecturing this poor patient.
I so love what you shared, Caroline, because it really empowers the patients and the families. But also, I wanted to share super quick about that lecturing. You know, they hear all these information, but do they get a reward? So I wanted to share, there are apps out there actually that actually helps the patient keep track of their health, sugar, A1C, diet, and all those, but also give them rewards and recognition that they can actually share to family members. It gives them, some boost and morale, kind of that, hey, I did well. I did exercise today. I got a badge. I don't want to mention any of these apps, but there are apps out there who can actually increase the patient's confidence level and empower the family members as well. Well, believe it or not, we're just about out of time. But before we go, let's quickly summarize what we've learned. Don't forget to involve the patient in the process and the conversation. Assess what the patient understands about their disease to meet them where they are to tailor their education. Help your patient discover possible appropriate substitutes for things they enjoy eating and drinking, and consider creating a diabetes box or a discharge worksheet with results, educational materials, and resources available to patients and their families. And suggest reward-driven mobile apps that can help increase patients' confidence levels and empower the family as well. Thanks for joining us. We'll see you next time.
We look forward to connecting with you on the next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org.
I'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners.
I invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add hashtag MedSurgMoments to your posts. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Caroline.
Laura.
Neil.
And this is Maritess. And always remember, Med Surg Moments is a moment in our lives, a moment in our Med Surg careers that makes a huge difference.